participant to this panel. I would like to thank Tehran University of Medical Sciences and also Oral and Maxillofacial Pathology Department of School of Dentistry and also Cancer Institute Hospital, and additionally APRAISE to raise team for supporting us to hold this panel. Also, I would like to warmly welcome Professor Merva Soluk-Tekkesin, Professor of Department of Tumor Pathology of Institute of Oncology from Istanbul University of Turkey. She kindly accepted our invitation to join this panel. The title of this, the article will be talked about this is the World Health Organization classification of odontogenic lesions, a summary of the changes of the 2022 5th edition. Also, I would like to appreciate contribution of Dr. Nazanin Mahdavi. She's Associate Professor and Head of Oral and Maxillofacial Pathology Department of Tehran University of Medical Sciences, and also Dr. Hana Safar. She is Associate Professor of Cancer Institute Hospital of TUMS. Both of them kindly moderate the panels. And also I would like to thank Dr. Behnoud Besali and Dr. Maryam Hosseini-Rad. They kindly will have a presentation as appraisers of the article. Okay, Dr. Mahdavi and Dr. Safar, the panel is yours. Dr. Mahdavi, do you have my voice?
Yes, thank you very much, Dr. Shaki, for the nice introduction. I'm so honored to have you and dear Dr. Merva, a dear friend of mine, and dear Dr. Hana Safar, a very good pathologist, here in this panel. So I think if Dr. Safar and Dr. Shakib and also Merva agree with me, we start the discussion.
Of course, Dr. Mahdavi, thank you so much. It's really a pleasure. I'm really honored. And as you know, as I previously said, I'm not a oral and maxillofacial pathologist, and I'm a general pathologist interested in head and neck pathology. So today I am all ears to hear and learn from all you. Thank you so much.
Thank you. So I think we shall start with Dr. Vesali. Am I right?
Yes.
Yes. Hello, everyone.
Hello, Dr. Vesali. Dr. Vesali is the postgraduate student of pathology. So, Dr. Vesali, would you start, please?
Yes, of course. First, let me say hi to everyone online watching us. My name is Benign Vesali. I'm pathology resident of Tehran University of Medical Sciences. It's 12:13 in Tehran, and I'm so delighted and honored being here among you, dear colleagues and professors. This presentation is designed to share original article titled as a summary of the changes of new WHO classification of odontogenic lesions of 2022 5th edition by Professor Merva Soluk-Tekkesin and Professor John M. Wright. First, let me make an outline for you before starting. First, we'll have a brief review of odontogenesis. Then we will know the new 2022 WHO classification of odontogenic tumors. After that, we will talk about changes made in the new edition within each tumoral lesion, specifically in the framework of the original article. And at last, we will hear my colleague presentation, Dr. Maryam Hosseini-Rad, about jaw and odontogenic cysts. Okay, let's have a review of odontogenesis. In this image, you can see dental histologic instruction, including dental lamina, which is derived from ectoderm and have ameloblasts in its inner layer. Ameloblasts are cells responsible for enamel matrix secretion. The second part, which is mesodermal derived tissue, is dental papilla, which have odontoblasts in its outer layer, just next to ameloblastic layer. With dental matrix secretion of odontoblasts, we will have dentine. Another mesenchymal derived tissue is cementum, which forms the outer covering of dental root. Cementum is secreted by cementoblasts, which themselves compose inner layer of dental follicle. So now let's dive in the main discussion. Here you can see 2022 WHO classification of odontogenic tumors. As before, based on their biological behavior, they are mainly divided into two categories as benign and malignant. Benign tumors are classified into three major categories according to their histologic origin as epithelial, mesenchymal, and mixed epithelial and mesenchymal tumors. In this slide, you can see four ladders, which shows each tumor category. Three main benign categories are painted blue, and malignant main category is painted orange, as you can see. In the case of lack of time, I skip reading each tumor. Soon we will talk about them separately. Unlike past editions, where malignant odontogenic tumors were discussed first, in the current edition, benign tumors are placed first and malignant ones are placed last. So we begin with benign tumors and adenomatoid odontogenic tumor as the first one. Okay, adenomatoid odontogenic tumor, or AOT. So what's new about AOT? It has a detailed differential diagnosis section and molecular updates. The first four differential diagnoses, which are odontomas, adenoid ameloblastoma, which is a new entity, adenomatoid odontogenic hamartoma, and adenomatoid dentinoma, may contain AOT-like areas. And about the last one, conversely, AOT can include calcifying epithelial odontogenic tumor-like areas. As it's mentioned, adenomatoid odontogenic hamartoma and adenomatoid dentinoma are not included in 2022 classification. It's obvious that clinical radiologic evaluation is necessary to avoid misdiagnosis due to the histopathologic overlapping. Regarding to molecular profile, KRAS mutations and MAPK pathway activation are the most common features of AOT. On these two images, you can see AOT microscopy, which on C, there are odontogenic epithelium in solid nodules surrounded by fibrous capsule, and on D, duct-like structures and calcifications, you can see. Okay, calcifying epithelial odontogenic tumor, or COT, now has three separated subtypes, such as clear cell COT, cystic microcystic COT, and non-calcifying Langerhans cell-rich COT. In the previous edition, these were explained in the microscopic and histopathological sections, but not as separate subtypes. However, no clear differential diagnostic criteria are proposed to separate the non-calcifying Langerhans cell-rich COT from the amyloid-rich subtype of odontogenic fibroma, which we will get to soon. It's stated that these are likely the same tumor, but are classified as COT by some and as central odontogenic fibroma by others. However, amyloid-rich odontogenic fibroma is used more often in terms of morphological and molecular features. Although different mutations have been reported in studies for COT, none of them currently affect treatment and diagnosis. Okay, on these three pictures, we're looking at COT. On B, there are polygonal epithelial cells with monocular polymorphism arranged in sheets. On C, there are islands of odontogenic epithelium with focal calcification and amyloid. On D, it's showing amyloid material stained by conjugate stain. Okay, ameloblastoma unicystic, which still has three subtypes according to distribution of proliferation of ameloblastomatous epithelium, which are luminal, intraluminal, and mural. There is general agreement that the first two subtypes can be treated conservatively, but the last one might need to be treated as ameloblastoma. The debate continues on whether the mural type is the type of conventional ameloblastoma or not. However, in the new and previous edition, it was left under unicystic ameloblastoma. It seems to be placed somewhere in between conventional and unicystic ameloblastoma in terms of recurrence and might require more extensive surgery for aggressive and destructive lesions, as said before. BRAF mutations have been found in all types, which makes BRAF targeted therapy a consideration for the treatment of mutation-positive cases. Excluding odontoma, which is considered a hamartoma, amyloblastoma conventional is the most odontogenic neoplasm, which is benign but locally infiltrative neoplasm composed of amyloblast-like cells and stellate reticulum. In 2017 edition, the genetic profile of amyloblastoma was updated broadly. BRAF is the most common activating mutation affecting the MAPK pathways and is an early and critical event in the etiopathogenesis of amyloblastoma. These are showing different patterns of amyloblastoma conventional, and B, you can see follicular pattern, while cells show palisading pattern with reverse polarity and looser state reticulum-like or squamous change in the center. On C, it's showing plexiform pattern with cords and strands of epithelium. And on D, it's desmoplastic pattern with epithelial islands in a dense stroma. Adenoid amyloblastoma, which is the only new entity and the most important change from the previous edition, which approximately 40 cases have been reported in the literature so far. It usually presents as a painless swelling with an incidence peak in the 4th decade with a slight male preference. In the microscopy, the essential diagnostic criteria have been described as an amyloblastoma-like component, duct-like structures, pores or morals, and cribriform architectures, while dentinoid, clear cells, focal ghost cell keratinization are reported as desirable features, but not as essential diagnostics. An IHC study variable staining for cytokeratin 14, cytokeratin 19, P40, P16, and P53, and positive nuclear reactivity for beta-catenin has been reported. Ki-67 proliferation index is usually high, which can explain the local aggressive behavior with a high recurrence rate, something between 45 till 70%. What is interesting about adenoid amyloblastoma is that in contrast to other intraosseous ameloblastomas, BRAF mutations have not been found in adenoid ameloblastoma. The lack of BRAF reactivity and finding of nuclear beta-catenin reactivity in these tumors raises the question, is adenoid ameloblastoma the best designation for this new tumor? The main differential diagnosis for adenoid ameloblastoma includes AOT and dentinogenic ghost cell tumor, but these tumors do not show the essential criteria of adenoid ameloblastoma. Clear cell odontogenic carcinoma and odontogenic carcinoma with dentinoid are also in differential diagnosis, but the clear cell odontogenic carcinoma includes EWSR1 rearrangement, while distinguishing adenoid ameloblastoma from the odontogenic carcinoma with dentinoid can be difficult, as there are few clear distinctions so far. Okay, on these images, you are looking at adenoid ameloblastoma microscopy, which on C, you can see characteristic cribriform architecture with pseudocysts and duct-like structures and holes. And on D, there are duct-like clear cells associated with dentinoid matrix. Okay, metastasizing ameloblastoma is defined as an ameloblastoma that has metastasized despite its benign histopathological appearance, which is still controversial in terms of its classification. Just to note, this tumor was classified under the odontogenic carcinoma section in 2005, and then classified under the benign epithelial odontogenic tumors in 2017. As well as in the current edition. The challenge is characterizing metastasizing ameloblastoma at the molecular level and whether its genotype is sufficiently distinct to allow metastasize despite its bland morphology histologically. The solution of the classification issue, which contradicts its name, seems to be left to the next classification. Okay. Benign epithelial tumors with no significant changes are a squamous odontogenic tumor and ameloblastoma extraosseous peripheral, which still has a separate entity status, unlike other peripheral odontogenic lesions. Okay, The next section is about benign mixed epithelial and mesenchymal odontogenic tumors and odontoma as the first one.
Thank you, Dr.
Yeah,
Vesali.
Thank you. Thank you so much.
That was a great presentation. We have Dr. Josh Hill and Dr. Tilak Ratne with us in this session. Thank you very much, professors, for joining us. It is a great pleasure to have you here. So please, just anytime you need to add some description, just turn on your microphones and let us know your opinion. Merva, I think, as mentioned before, the only new entity added in the new classification of odontogenic lesions is adenoid ameloblastoma. I think you entity.
Thank you, Nazanin. Thank you so much for this nice presentation. It's an extremely clear presentation by one. Thank you so much for this.
Thank you so much. Thank you.
Yeah, that's great. Yes, adenoid ameloblastoma, only the new entity, just we include the new classification. And also with the Tehran University of Dentistry Faculty, we have a collaboration study with the adenoid ameloblastoma to understand what it is. Actually, it's really different molecular aspects with the classical ameloblastoma. So we have to need some more explanation and some more molecular studies to understand if it's a subtype of the ameloblastoma or different entity. But until now, we just accept it is a kind of subtype of ameloblastoma. But today we know that they haven't got any BRAF mutation, which is more common in the classical ameloblastoma. Yes, there are some differences in the histopathological pictures, just we see together. The most important one, we see the ameloblastic epithelium, but also we see the crib reform architecture. That's the most important ones. Also, in my experience, we haven't got lots of cases, but dentinoids and some clear cells also associated with this unique lesion.
Thank you very much, Merva. My question is, does it need for more aggressive treatment?
I think that the ameloblastoma is enough aggressive tumor. So I don't think it's so different from the classical ones. It depends on the radiological features and the size of the tumor. All of them also the same with the classical one. So until now, yes, I see some of the adenoid ameloblastoma have a very large and destructive lesions, but also we have one, it's a very small, but show all the histopathological features of the adenoid ameloblastoma. So I think the answer is it depends on the case. No,
Sorry.
Puyan just asked a very nice question. Is molecular study is mandatory to make the definitive diagnosis of this unique ameloblastoma? No, the architectures of the classical crib reform architectures, it's really different from the classical ameloblastoma. So I don't think we need the molecular studies for the diagnosis, but we need these studies to understand its nature, its origin, to understand.
Thank you very much. Thank you very much, dear Merva. Professor Hill, is there anything you want to add? Hello, Professor Hill. And Professor Chilakratne, if there's anything you want to add, we are all ears.
I also thank the Dr. Hills and Dr. Tilikaratne to join us. Thank you so much.
Thank you very much. So I think we can continue with the benign mixed epithelial and mesenchymal odontogenic tumors.
Sorry, Dr. Mahdavi, for interruption. We have a participant, Dr. Badrana. He has raised his hand for a question, I think. Zohre, would you please let him to turn on his microphone and also. Zohre, would you unmute Professor Jos Hill and also Dr. Badrana?
Good afternoon, everybody. I have a small question. What is your experience with adenoid ameloblastoma, with its location, site? Is it similar to the third molar area, or is it the maxillary region that is more common? I'm just, cribriform pattern is something that goes towards the salivary gland or something like that. So just seeking any experience, what's the most common location and site, and what are its prevalence and all those things, the clinical evidence, how close or how far is from the conventional ameloblastoma? Thank you so much for the opportunity.
Thank you for the question. Actually, due to its rarity, it is a little bit difficult to say this. It's tend to be maxillary or mandibular side, but we have a study now, and we have the most of our cases in the mandibular molar side. But when we look at the literature, you can see most of the cases in the maxillary side. So it is a little bit early to say that it's the predilection for mandibular or mandibular. We will see when the case is increasing, we will see the exact predilection. Another question for the, actually for the radiological pictures and clinical symptoms, it's not different from the classical ameloblastoma. Under the microscope, with the histopathological features exactly different from the classical one. As you said that the architecture, reform architecture is similar with the salivary gland architecture, we call this, what is the cribriform. So I think we need more and studies and to increasing these cases in the literature, both clinical features and histopathological features. I think it's okay.
Thank you so much. Dr. Mahdavi, can I ask a question, please?
Please.
Dear Merva and all our audience, I wanted to know that for diagnosis of ameloblastoma, how often can we see holes and morals in ameloblastoma? Is it common to find many regions with holes and nodules in conventional ameloblastoma?
A good question again. Actually, for my experience, I never see such morals and such the nodules in the classical ones. Maybe only I can say that the ameloblastoma with dentinoid cases, now we call this adenoid ameloblastoma. When I look at my archive, if after that this description, if the cases have some dentinoid material, at that time I can see some morals. But in classical ameloblastoma, always never see such morals and the nodules in. Nazanin, do you have any experience in the classical ameloblastoma with morals?
So yes, I was muted. Actually, I haven't seen any.
Yeah. Okay.
Thank you so much. Thank you. Thank you so much. Thank you, dear Merva.
You're welcome.
Thank you very much, Dr. Safar and Merva. We have also Professor Hill with us. Professor Hill, would you please let us know your opinion about it?
Good morning, everybody, or good afternoon.
Good morning.
Thank you very much for asking the question. so far as we're concerned, we have not identified the adenoid amyloblastoma in our series, but that might be because we might have missed it. So it is for me also quite a learning lesson just to see how the studies actually have evolved around it. But my question is, why have somebody done all these studies like P14, P16, and on this tumor, where has it been done on other ameoblastomas? So is there a difference?
Did you ask for the P16, right?
Yeah, and P40. I know I've never used P40 on an ameoblastoma.
No, I also never use for the ameloblastoma cases, and including the adenoid ones. Just for the adenoid ones, maybe beta-catenin staining show positivity in the models of this adenoid ameloblastoma. But I have no experience with the P16, and I don't think is there any meaning to make a P16. Thank you.
Yeah. The other comment that I'd like to make is on the adenomatoid odontogenic tumor. I know that there is some studies now that there's KRAS mutation, but does it really mean that it is actually a tumor and not a hematoma? Because we always think that most of them actually start in the follicle and then have very, very limited growth potential, and typically occur also at an age where you could expect hematomas to grow.
Yeah, absolutely agree. The differences, the line between the hamartoma and the tumor is a little bit difficult for the odontogenic tumors. So I absolutely agree. We are also make an international consortium to understand which are these tumors, are the hamartomas and which are not. Also for the AOT in the section, we also used some adenomatoid odontogenic hamartoma or adenomatoid dentinoma, something like hamartomatous lesions. But I think we need again more study until the next classification to understand that if they are true tumors or hamartoma. The most difficult question is here, how we can understand if it is tumor. It's enough to see some mutation. Can we call this it's a tumor or not? I think that's the problem, and I totally agree that maybe adenomatoid odontogenic tumor could be a hamartoma. Yeah.
I just got a message from a staff member that to say there's a possible case at Grootspier Hospital of the first entity that we discussed, the adenoma amyoblastoma. So we'll have to see about that one and do the studies. But thank you very much.
I thank you. Thanks so much for your valuable comments.
Thank you very much, Professor Hill. We can answer to one question in our chat box only. The question is, can a combination between AOT and ameloblastoma lead to misdiagnosis of adenoid ameloblastoma?
Very good question. Yes, sometimes in the adenoid ameloblastoma, we see the AOT-like features. But again, the most important thing, again, the histopathology with the clinical features. Where is the tumor? Especially, we know that the AOT especially likes the anterior part of the both jaws, and also a little bit younger than the adenoid ameloblastoma cases. So we should evaluate all these cases with the clinical radiologic features together. Otherwise, you are so right. Maybe we can wrong misdiagnosis. Only we look at these histopathological features.
Thank you very much, Merva and Professor Hill and Dr. Safar. I think we can continue with the next odontogenic tumor.
Okay. Okay, let's move to benign mixed and benign mixed epithelial and mesenchymal odontogenic tumors, and odontoma is the first one. Odontoma is now considered a hamartomatous odontogenic lesion which has compound and complex types. there is a very detailed discussion about ameloblast fibroadontoma or AFO and ameloblast fibrodentinoma or AFDE here. And they were excluded from the previous and current classification because most of them were presumed to represent developing odontomas. However, we have BRAF mutation in AFD and AFO like ameloblast fibroma, but different from odontoma, which supports that at least some of these lesions are in fact neoplastic. Specifically, we're talking about those with locally aggressive behavior, large size, and recurrence. There is also a recent study implying that the combination of age and lesion size may be used to distinguish between these lesions of a true neoplastic nature, like AFO, and hamartomatous formation like odontoma. So it's obvious that we need further molecular and genetic specification to better understand their true nature. Ameloblast fibroma. Both odontoma and ameloblast fibroma sections of the new edition have a discussion about AFO and AFD compared to previous editions, and this may indicate a need for further clarification of these lesions in the next classification. Okay, now again, tumors with no significant changes from benign. Mixed and mesenchymal ones include primordial, odontogenic tumor, and dentinogenic gosal tumor. All right, let's turn to benign mesenchymal odontogenic tumors and odontogenic fibroma as the first one. Odontogenic fibroma, what we know today is that it has subtypes, amyloid subtypes, granular cell subtype, ossifying subtype, and hybrid odontogenic fibroma with central giant cell granuloma. The question arises here is where should we put amyloid type odontogenic fibroma in classification regarding to its similarity to non-calcifying Langerhans with COT? Which one should we use? Cementoblastoma now has some molecular updates and shows CFOS overexpression like what we see in cementoblastoma, which is a histologic mimicry. This raises the question of cementoblastoma being a unique odontogenic tumor bone neoplasm within the spectrum of osteoidostoma and osteoblastoma. Cemento-ossifying fibroma or COF, while COF has always been a benign fibrosis lesion as well as odontogenic neoplasm, it's now defined and updated under the odontogenic tumor section. About molecular updates, a variety of infrequent molecular alterations with no pathogenic changes have been reported in COF2. Okay, let's have a brief review on COF microscopy. On the image labeled as C, we have a benign fibrosis lesion with trabecular matrix, cellular inclusions, and osteoblastic ring-like bone. On the image labeled as D, we have a smaller, rounder, and acellular matrix resembling cementum. Okay, odontogenic myxoma has some updates in its pathogenesis that shows MAPK-ERK pathway activation, which implies that inhibiting this pathway can lead to reduced tumor growth. It's also worth emphasizing, as the previous edition did, that the most important differential diagnosis of odontogenic myxoma is two histologically identical: the dental papilla of a developing tooth and the normal as well as hyperplastic dental follicle. So in these circumstances, we should know well these anatomic sites and correlate with clinical and radiology features. In this study, you're looking at picture B, which shows odontogenic myxoma, and picture D, which shows dental follicle. Just look at the histologic similarity between these two. There are also rests of odontogenic epithelium, which can be seen in odontogenic myxoma too. Okay, now the last section of my presentation, which is malignant odontogenic tumors. Just to let you know before going through, there are not many significant differences between the last two editions in this section, and we are just going to have a brief review of each tumor in the framework of the original article. Okay, the first one is a sclerosing odontogenic carcinoma. It's very rare. Due to its rarity cases, there are no molecular updates or developments, just as minor change not having the potential for metastasis was added to definition of SOC, or sclerosing odontogenic carcinoma. Just to review microscopy, we can say it's characterized by bland cytology, markedly scleroting stroma, and locally aggressive infiltration. The question is, now that this neoplasm has no metastatic potential, should it be categorized as a carcinoma? Ameloblastoma carcinoma, which was described as a malignant counterpart of ameloblastoma previously, now has a definition change from the previous edition, which implies it's the primary odontogenic carcinoma histologically resembling ameloblastoma. BRAF mutations have been also reported in ameloblastic carcinoma, but it has no defined diagnostic value yet. Just to remind, BRAF mutation is the most common activating mutation in conventional ameloblastoma. Having a review of ameloblastic carcinoma in this slide, on picture B, you can see follicular growth of tumor cells resembling ameloblastoma. On C and D, we are looking at significant cytologic atypia and dyskeratosis, and also clear cell change on picture D. Clear cell odontogenic carcinoma has no significant changes, but as a quick review, we know that more than 80% of cases harbor a translocation involving WSR1 and ATF1. Another part worth saying is the differential diagnosis of tumor, which is broad and includes almost all clear cell-rich tumors, including odontogenic tumors, salivary gland tumors, and metastatic tumors, especially renal cell carcinoma. The distinction may require IHC and molecular studies in some challenging cases. The next tumor is ghost cell odontogenic carcinoma. It has limited update on molecular aspects because of the rarity of the tumor. In the new edition, a single case documented mutation of ptycatenin or CTNNB1 and the novel APC mutation has been added to the previous molecular profile. Okay, primary intraosseous carcinoma, not otherwise specified, is usually a squamous carcinoma with variable differentiation, but mostly moderately. And majority of them arise from odontogenic cysts, more commonly residual and radicular cysts, and less often dentigerous and odontogenic keratocysts. And first exclude others. So this diagnosis should be made carefully after excluding other malignant odontogenic and intraosseous salivary gland tumors, metastatic lesions, and carcinomas invading bone from other anatomic structures. In this slide showing primary intraosseous carcinoma on picture B, we see features of a cyst. On C, we have an invasive component and dyskeratosis, and on D, it shows significant atypia. Odontogenic carcinosarcoma is an extremely rare malignant odontogenic tumor containing both malignant epithelial and mesenchymal components that require very careful examination. Any sarcomatoid change in a malignant epithelial odontogenic tumor should be evaluated carefully to avoid misdiagnosis of a spindle odontogenic carcinoma. Odontogenic sarcomas are a group of malignant odontogenic tumors, including ameloblastic fibrosarcoma, ameloblastic fibrodentinosarcoma, ameloblastic fibro-odontosarcoma. At least 24% of ameloblastic fibrosarcomas arise in benign or recurrent ameloblastic fibroma. Fibrodentinosarcoma and ameloblastic fibro-odontosarcoma are different from each other by enameloid matrix presence in the latter. Okay, odontogenic carcinoma with dentinoid is reported but not included as a separate entity in 2022 classification, but is mentioned frequently in the differential diagnosis of other odontogenic tumors, and its placement in the classification remains controversial, which may need a clarification. Thank you so much for your time and patience. In the next section, we talk about jaw and odontogenic cysts, presenting by my colleague, Dr. Maryam Hosseini-Rad.
Thank you very much. Dr. Vesali, for your nice presentation.
Thank you so much. Thank you.
So before going to malignant odontogenic tumors, regarding benign mixed epithelial and mesenchymal odontogenic tumors, I remember that Merva, you had a beautiful presentation in IOP conference with Marilena about how to differentiate ameloblastic fibro-odontoma from developing odontoma. And in this article is mentioned that age and size could be helpful. Can you please tell us how we can use age and size to differentiate between these two lesions?
Okay, thank you so much, Nazanin. This is one of the favorite topic in odontogenic tumors. Actually, before the size and the age, we have to look at the histopathological features very carefully. For my experience, if I see ghost cells, cyst-like structure, some cementum, cores and struts of odontogenic epithelium in a mature but loose connective tissue, lobulated structure, hypercellular areas only around the epithelium, and the ordered hard tissue production. At that time, my diagnosis, a developing odontoma or odontoma. Please be careful for these features to call any lesion ameloblastic fibro-odontoma or fibrodentinoma. That's very important histopathologic features to make the diagnostic pathway. But when come to the Dr. Nazanin question, especially the larger lesions, it means that if I'm not wrong, 2.1 centimeters in diameter, and the young patients, which means that the younger than the 13, at that time, with these all histopathological features, and with this age and size, at that time, you can give the diagnosis of ameloblastic fibro-odontoma. When we look at the literatures, it's really complex and the most of the different diagnoses with this. So we have to be very careful histopathological examination. After that, if we agree all these histopathological features comfortable with the ameloblastic fibro-odontoma, there is no question. But if you are between the developing odontoma and ameloblastic fibro-odontoma in terms of the histopathologic features, at that time you can use the size and the age. This is very challenging. Yeah, I know.
Yes, but thank you very much for your explanation. That makes me clear. Thank you. And regarding the malignant epithelial tumors, we have a question from Dr. Shakib. Is there any cutoff for Ki67 expression to differentiate between ameloblastoma and ameloblastic carcinoma?
Actually, for the ameloblastic carcinoma, it should be marked atypia. So actually, we don't need any Ki67 for that cases, because when we look at the ameloblastic carcinoma, the malignancy is so clear. If you are think that this atypia may be a little bit not so distinct, at that time, please go and look at the slides again if it's ameloblastic carcinoma, because we have some ameloblastic carcinoma, maybe the most common odontogenic malignancy in my department, and we see really marked and a very clear atypia. But if you ask me for the Ki67, it depends on the, sometimes we can see the increasing Ki67 in the benign lesions, because ameloblastoma also in the local aggressive lesions, we know that. So the first thing I'm looking for the ameloblastic carcinoma is distinct atypia.
So I should continue with the
Sorry, Dr. Ma.
yes,
Sorry.
please, Dr. Safa.
Hello.
I think that's
Yes.
Dr. Hill.
Sorry. Can I ask a question, please? I
Yes,
wanted
please,
to
we should
ask from dear Merva. Thank you. How can we differentiate ameloblastoma desmoplastic type from ameloblastic fibroma? Can they mimic each other?
Yeah, actually, we have really different stroma. For the desmoplastic ameloblastoma, we see very distinct stroma and a very narrowed ameloblastic epithelium. But for the ameloblastic fibroma, the stroma looks like dental papilloma-like appearance, and with a very distinct ameloblastic epithelium. So the most important differences, ameloblastic fibroma and desmoplastic ameloblastoma, is the stroma. You should very carefully stroma to understand between its differences.
Thank you so much.
You're welcome.
And I guess also that radiographically they differ. The one is much more aggressive than the other, I would say.
Thank you. Yeah.
Can I, may I comment on how much time do we have on the odontomes, or are we finished with it? I think, may I speak to it?
Yes.
Yes, please.
I think that your explanation about a developing odontome versus an odontome that putatively has arisen in an ameloblastic fiber odontome is the best that I've heard so far. I think there are three types of odontomes. There are two developing odontomes. The one is the compound odontome, and the other one is the developing complex odontome, which are direct, basically deformations of the dental lamina in a hematomatous and are of a hematomatous nature. And we see sometimes, as you said, some more complex, sometimes ghost cells, sometimes a bit of, more dense stroma around the complex odontome. But I think that I have seen a lot of complex odontomes that had a follicular membrane or a follicular tissue around it, which for me means that it was more developmental than it is a neoplastic. And I think it arises from an invagination of, you first have a dilatation of the dental lamina, and then you have invaginations. In other words, instead of a dilatation or differentiation to single tooth-like structures, you have invaginations, which actually brings it to a very complex arrangement of dentine and enamel and even pulp tissues in reverse deposition. And for me, that is a very good indication that this was a hematomatous or developmental lesion. I have got not an experience with an ameloblastic fiber odontome that is completely matured into an odontome where there is no stroma left, typical neoplastic stroma left to identify that it actually really was deriving from a developing neoplasia. And the question is, in the literature, how often has it been proven that these, of course, we've seen ameloblastic fiber odontomes developing the hard dental tissues, but where has one seen these so compact as you find them, for example, in the hematomatous type, the developmental complex odontome?
Nazanin, can I continue?
Yes, please.
Thank you so much. Yes, you are absolutely. I agree with your comments. Actually, we have to need some more molecular studies. Just we start with the Professor Ronald from the Argentine, we start to make some molecular studies with the ameloblasttic fibroadenoma and dentinoma to find the differences between the challenging cases. But I believe that some of the cases in the literature and in my experience, they are absolutely neoplastic in terms of the clinical behavior and size and their histopathologic features. But honestly, we need some more clue to get this is the different and distinct entity. So I think we need some time to finish these studies. Thank you.
Thank you. Thank you very much, Professor Hill. Thank you very much, Professor Merva, for your explanation. So we are a little bit behind the schedule, so we should continue with odontogenic cysts. The next session will be presented by a postgraduate student in pathology, Dr. Hosseini Rad. Dr. Hosseini, please, we are all ears to hear your presentation.
Hello everyone, it's a great pleasure to meet and present to you today. Thank you for Dr. Sally for the amazing presentation. The topic that I will be covering in my talk is a cyst of a jaws and a summary of the changes of 2022 edition of WHO classification. In the 2017 classification, the cysts of a jaws are divided into two primary parts: odontogenic cyst of inflammatory origin, odontogenic non-odontogenic developmental cyst. Now, in the 2022 classification, the umbrella term of cyst of a jaws has been used without any subdivision. However, for greater clarity and to emphasize their origin, here we prefer to discuss them under the subheading of inflammatory odontogenic cysts, developmental odontogenic cysts, other cysts of a jaws. You can see here the subheading of cysts of a jaws and their subdivisions. I divided the presentation into three parts. In the first part, inflammatory odontogenic cysts, and in the second part, developmental odontogenic cysts. Finally, I go on to talk about other cysts of the jaws. Table 3 highlights the essential diagnostic criteria along with age, gender, and the localization preference of all odontogenic cysts, surgical ciliated cysts, and nasopalatine dark cysts. For example, radicular cyst is an inflammatory odontogenic cyst that occur with peak in 4th and 5th decades of life in a slightly man, and the maxilla is the most common site. Now, let's move to the first subtype of inflammatory odontogenic cyst, radicular cyst. Radicular cyst is still the most common cyst of a jaws and accounts for about 60% of all odontogenic cysts that arise from pre-radicular inflammation secondary to the spread of odontogenic infection resulting from tooth revitalization. Residual cyst, which was clearly mentioned as a subtype of radicular cyst, is found as a well-defined side of prior to the extraction when the radicular cyst was not removed when the offending tooth was extracted. Lateral radicular cyst terminology of 2017 has been abandoned and only mentioned as radicular cyst that can be located on the lateral aspect of the root associated with the lateral root canal. Figure 9 shows radicular cyst. Figure A reveals crapanomic radiograph, and Figure B shows non-keratinized stratified squamous lining epithelium with epithelial hyperplasia in a characteristic arcading pattern. And Figure C is a crapanomic radiograph, and Figure D is a residual cyst showing less inflamed wall and a more regular thin epithelium. Inflammatory collateral cyst is an inflammatory odontogenic cyst that have no major changes and continue with two distinct subtypes as paradental cysts and mandibular buccal bifurcation cysts. The histology is not specific and indistinguishable from residual cyst features. The second subheading is developmental odontogenic cysts that divided into gingival cysts, adult and infant types, dentigerous cysts, orthokeratinoid odontogenic cysts, lateral periodontal cysts, and botryoid odontogenic cysts that continue in the 2022 classification without important changes from the previous edition. Regarding molecular updates, BRAF mutations found in ameloblastoma have not been found in dentigerous cysts. Classifying odontogenic cysts, or COC, has continued in the cyst classification with an important change in the definition that also affects the diagnostic criteria. Classifying odontogenic cysts is now defined as a developmental odontogenic cyst characterized histologically by ghost cells, which often calcify. While most COCs still have ameloblastoma-like epithelium, that feature was moved from an essential feature to a desirable criteria. Mutations of CTNNB1, which encode beta-catenin, has been added to the COC pathogenesis. Let me show figure 11 about calcifying odontogenic cysts. Figure A is a panoramic radiograph. Figure B is a low power, shows a cystic architecture with prominent eosinophilic polyhedral cells or ghost cells. And figure C reveals focus of ghost cells, some of which show calcification. And figure D shows characteristic ghost cells where the nucleus is lost, but cytoplasmic outline are maintained. And glandular odontogenic cysts, or GOC, also has some differences from the fourth edition in terms of diagnostic histopathologic features. In 2017, 10 different histopathologic features were described, and observation of at least 7 criteria was suggested to make a GOC diagnosis. The new edition emphasized that even if characteristic, not all features are present in all cases, but more features provide more confidence in the diagnosis. Among these features, the essential criterion is presence of a lining epithelium with varying thickness, but it was stated that hobnail cells are observed in almost all cases and seem to be the most characteristic feature. It was also emphasized in the classification that the most important differential diagnosis of GOC is intraosseous mucoepidermoid carcinoma, demonstrating the mammal 2 rearrangement for intraosseous mucoepidermoid carcinoma is important in the differential diagnosis of these two lesions. That is still generally accepted. However, one GOC case has been reported with mammal 2 rearrangement. It is believed that this situation needs further studies. You can see figure 12, glandular odontogenic cysts. Figure A is a cropped panoramic radiograph. Figure B is axial CBCT, and figure C shows cyst lining of variable thickness with a large eosinophilic hobnail cells on a luminal surface. Hobnail luminal cells with mucus cells and occasional clear cells in figure D. Odontogenic keratocyst, or OKC, is the most frequently researched cyst due to high recurrence rate, aggressive clinical behavior, and association with the nevoid basal cell carcinoma syndrome. In the 2022 edition, OKC continues in the cyst classification and has the longest section among the cysts of a jaws. There is extensive literature characterizing the molecular landscape of OKC, must show mutations of the tumor suppressor gene PTH1, but rarely PTH2 or CU and U. These mutations have fueled the continuous spirited debate about whether OKC is a cyst or a cystic neoplasm. In 2000, 5, odontogenic keratosis was changed to a cystic neoplasm and designated a keratocystic odontogenic tumor. It was moved back into the cyst category in 2017 and continues the cyst in a fifth current classification. The debate continues. And figure 10 compares orthokeratinosis odontogenic cyst versus odontogenic keratosis. Figure A is a crop panoramic radiograph. Figure B shows orthokeratinosis odontogenic cyst that is lined by a uniform stratified squamous epithelium with orthokeratosis, prominent granular cell layer, and bland and palisaded basal cells. Figure C is crop panoramic radiograph showing a multilocular radiolucency of the left mandibular body and ramus. Figure D reveals odontogenic keratosis that is lined by a uniform stratified squamous epithelium with a corrugated surface of parakeratine and palisaded and hyperchromatic basal cells. All right, let's turn to the other cystophages with two subdivisions, surgical ciliated cysts and nasopalatine duct cysts. At first, surgical ciliated cyst, not a new entity, but new to the classification, is a rare non-odontogenic cyst lined by respiratory epithelium as a result of the traumatic implantation of sinus or nasal mucosa. Surgical ciliated cysts of the maxilla, postoperative maxillary cysts, or respiratory implantation cysts are other terms used for this entity. The most common age range is the 5th to 6th decades with no gender predilection. As the definition indicates, it occurs most commonly in the posterior maxilla, but very rarely in the mandible due to implantation of sinus epithelium by contaminated instruments or using nasal bone or cartilage with epithelium for augmentation genioplasty. Histopathologically, the cyst is lined by ciliated pseudostratified columnar epithelium and mucous cells are common. A history of previous surgery is an essential criterion for diagnosis. Treatment is simple enucleation and recurrence is rare. Figure 13 is a surgical ciliated cyst. A is a crop panoramic radiograph showing a well-demarcated unilateral radiolucency of the left maxilla with a history of traumatic tooth extraction. Figure B is a cyst lined entirely by respiratory epithelium. Figure C shows intraoperative view of the case located right side of the maxilla. This case in figure D shows hyperplastic pseudostratified ciliated columnar epithelium with mucous cells and inflamed cyst wall. Awareness of this entity prevents misdiagnosis. Nasopalatine duct cyst is the most common non-odontogenic cyst of the jaws, about 80%. The cyst is lined by non-keratinized squamous epithelium or respiratory epithelium in variable proportion with focal areas of cuboidal, columnar, or ciliated changes. Generally, the neurovascular bundle is seen in the wall of the cyst, but this is a feature of sectioning that this feature is included in a desirable diagnostic criteria. To sum up, the new 2022 WHO classification of odontogenic tumors and jaw cysts includes some modification and developments briefly summarized. This summary becomes a resource for readers to find recent changes and critical diagnostic information. At the end, I want to thank Professor Tekkesin and Professor Safar and Professor Mahtabi for giving me this opportunity to present to you. And I want to thank for your precious time.
Thank you very much for your presentation. Dr. Safar, is there anything you want to add or any comments?
I would like to thank Dr. Hosseini Wright and
Thank you.
Okay, yes. I would like to thank dear Dr. Hosseini Rad and Dr. Vestali both for their nice presentation. Thank you all again. And Dr. Mahtabi, I think Dr. Shakib had a question in chat box, and it's my question as well. Thank you.
Okay.
Dr. Shakib, would you please let us know your question?
Yeah, I have just seen. Okay, Puya.
Okay, thank you very much for the presentation. I sent my question in chat box. Professor Keith Hunter and his colleagues has recently published a very interesting article about keratoameloblastoma. We have several cases similar to the cases reported by Professor Hunter, but I commonly reported them as solid odontogenic keratocysts. I'm not sure, but they may be similar cases, and I didn't find a significant difference between these two entities. But I think it is important for the clinician to differentiate an odontogenic keratocyst from an ameloblastoma in any kind of them. I will be grateful, Merva, if you would have any comment about the differentiation of these two entities.
Yeah. Thank you, Puya. Yeah, I have also read this paper. I think it's Keith Hunter and from the South Africa, Willy van Heijden, and it's a multi-center study. Yes, actually, for this classification, they haven't got any use of the solid odontogenic keratocyst names or keratoameloblastoma terminology. But the last classification, they also say that the WHO say that some solid islands with the keratocyst daughter cyst without cystic structures, yes, you can call it solid odontogenic keratocyst, but actually we don't know exactly what is this. If Dr. Tilikaratne here, maybe if they make any comment, I'm really happy to hear that. But this is another challenging one. I think from the odontogenic cyst, the keratocyst is a really different behavior, recurrence, and types. This is the challenging, the basis continue during all classifications, and we are waiting for some new things for the next classification, included this solid odontogenic keratocyst. And as I said, if Dr. Tilikaratne give his valuable opinion, I would appreciate.
Thanks, Merva. I actually had another meeting and I missed most of the meeting, but yeah. Now, as you correctly said, we have mentioned without much clarification about solid type odontogenic keratocyst in the new edition. But yes, it's a little controversial area. Still, we don't have enough sound evidence to call it. It's definitely an entity. That is why it does not stand on its own as a separate entity. But as Puan said, keratoameloblastoma has been there for ages, right? It has been there for 1970s. People diagnosing. Some people call it those days papilliferous keratoameloblastoma. But yes, there are keratin producing ameloblastomas, but solid type odontogenic keratocysts, in my experience, I have seen a couple of them. They're slightly different from the keratin producing ameloblastomas, where you get the small islands of the budding-like appearance in odontogenic keratocysts compared to the more strand-like keratocystic epithelium in keratoameloblastoma. But neither entities have, made it to the WHO classification as separate entities because we need more data. But only thing that we need to be careful is not to misdiagnose that as well-differentiated squamous cell carcinoma. Right. That has happened, that can happen. So that is the most important thing that reporting pathology should take into account. not to misdiagnose it as well-differentiated squamous cell carcinoma. In my opinion, to be on the safe side, if you have a slightest doubt, rather than calling it well-differentiated SCC, better to call it a solid type odontogenic keratocyst.
Thank you. Great.
Thank you so much. That's very clear. Thank you.
Thank you very much, Dr. Safar, Dr. Merva, Soluk-Tekkesin, Dr. Tilak-Ratne, Professor Hill, Dr. Shakib, for being here today. I would also like to thank the postgraduate students, Dr. Vesali and Dr. Husseini Wright, for the nice presentation. It was very good. Thank you very much. Thank you, and I would like to thank the audiences for being here today. It was an honor to have you here. Thank you. Professor Shakib, I think you want to share the certificate.
Yes, yes. I would like to express my appreciation to all the audience. And Zohre, are you ready to share the certificate of the appraisers and also moderators, and also absolutely the certificate as Professor Merva? Okay, great. Oh, great. The first, I think you have firstly shared. Oh. I think you are sharing your screen, Zohre. Zohre is one of the most talented IT women with us, and she's technically supporting us. But I think you're sharing your screen.
Only for today. Yes, I am sharing.
Okay.
I want to say a few words. I also sent the paper again, the last changes of the WH classification with the Professor John Wright. If you have any question, also you can send me email. You can find my email at the paper. And whenever you want, you can send your question. I try to answer all the questions, but I think maybe I missed some of them. If you send me email, I'm happy to reply it. And thank you so much again.
Would you please share your email in chat box, Merva?
Okay.
I would be very grateful if you would share it. Thank you. Thank you. It's very kind of you, and thank you. Received. And Zohre, are you ready to share? And I would like to invite all the audience to turn on the video for the thank you for the group photo at the end of the panel. Okay, great. Thank you very much for your time and attention, Professor Merva, and sharing your experience and knowledge with us.
My pleasure.
Very grateful. And next one, Dr. Safar, great pleasure to have you in this panel. Thank you for accepting our invitation. And
the pleasure is all mine. Thank you so much.
Welcome. And also, I would like to express my special thank to Behnoud and also Mariam. I know that they spend a lot of time to prepare this interesting presentation, and I would like to thank them, Mariam and Behnoud, for your time. And
it was a pleasure. Thank you so much. It was a pleasure. Thank you so much.
Welcome. And we are ready for the group photo at the end of this panel. And I hope, okay. Ready, okay. And hope to meet you all in the next meeting. I think it was a very informative meeting and great discussion, and contribution of all of you, especially Professor Hill and Professor Tila Karatne helped us to have an informative and very impressive meeting. Thank you very much. And thank you, Merva, for your time.
Thank you.
My pleasure. I thank you for your invitation. Thank you.
Welcome. And have a nice day. Bye-bye.
Thank you. Goodbye.
Thank you. Bye.
Bye-bye.
Bye.